Good afternoon, everyone. Nice to see some familiar names joining. And we'll give it another minute or two as people transition from clinic to echo or whatever you may be doing to echo. Hope everyone is doing well. This 10th day of June, or February as it feels here in the Northwest. Franja, welcome.
Hello, everybody, on this lovely Friday.
Lovely indeed. We'll give it one more minute here, maybe a half a minute. And inevitably, people will continue to filter in, and always welcome. Well, let's go ahead and get started. Again, I'm sure others will join as the session proceeds. So welcome to our kind of first out of our Core 10 series, kind of the next part of the year here. And hopefully you can see that screen okay. Still want, be 2 seconds here, working on a different machine today. Where is that? Interesting. All right, how does that look?
It looks good. We can see the slide.
Great. I have to reorganize some windows here. So welcome. And we will go through our usual agenda here, which is some opening notes and reminders. We democratically decided to skip introductions since we know each other pretty well at this point, and in lieu of making sure we have enough time for our didactic and conversation. And our didactic today is a fantastic one by Dr. Jessica Caldwell around sex and gender and Alzheimer's disease risk and resilience. And I'll tell you a little bit more about that in a second. Couple of reminders, if you would be so kind as to enter the names of all of your attendees, if there are multiple of you at your site, into the chat. Just a reminder also to mute your microphone when not speaking and say your name when you unmute. If you are in a place and able to do so, it'd be great if you can turn your video on, as it's lovely to see you all and get to know each other a bit better. Some other reminders, we don't have a case today, so there likely will not be much in the way of PHI to worry about, although if we are talking about clinical issues, just a reminder to do your best not to reveal any information that could reveal patients or family members. All of our sessions are recorded. And if you want to revisit this one or any other, they're available on our website. There's no login or anything like that, easy access. And then, of course, there is the ubiquitous 1-minute post-session survey as we continue to try to iterate this and make it the best possible program for you, our community. We have, today kicks off a fantastic rest of the calendar year in terms of didactics. There's really some fantastic topics and presenters. Those are also up on our website, so you can take a look at. We still have 2 that are in the process of being finalized. It is surprisingly difficult to find an expert around toileting and dementia. So if you know of one, please let us know. We've exhausted almost all of our usual resources. But also, as always, cases are such a critical component of this. The case-based learning, I always learn something. I think we always learn something. And no case is too simple. No case is too difficult. No case is kind of out of question here. So successes, challenges, please feel free to bring those forward. You can reach out to Allison or Nancy and I. We're in the same room for the first time, I think, in this session since the very first one. So nice to see you.
Wonderful to be here.
Yeah.
Great to see you.
We also are accredited for CME. So again, 1.25 credits, making sure you're claiming only the credit that's commensurate with your participation. No disclosures on the part of our speaker or our planning committee. We always do have a mitigation process should there be any conflicts. And as we always ask, if you receive any, please let us know. If you haven't already, go ahead and enter your name into the chat. This is a representation of where you are. I see Jeff Kaplan in Yakima there. I see Brett Earl in maybe in the Wenatchee area. And of course, our heavy representation over in the I-5 corridor over here too. So again, love to see you all. Here's our hub team, as indicated either by our titles or our backgrounds. And again, I'm Chris Rhodes, your honored co-lead with my distinguished co-lead, Dr. Eisenberg here. Okay, with that, I am so pleased to introduce Dr. Jessica Caldwell, neuropsychologist and director of the Women's Alzheimer Movement Prevention Center at the Cleveland Clinic in beautiful Las Vegas, Nevada. And with that, I'm going to stop sharing and turn it over to you, Dr. Caldwell.
All right, thank you for having me today. I'm going to share my screen. All right, does that show my slides effectively? All right, so I'm really excited to be here today. I think this program is so needed, and I really thank you all for inviting me to talk. So what I'll be talking about today is sex and gender in Alzheimer's disease risk and resilience. And I'll focus in on two factors that are emerging as potentially important as risks for women, and that can be things that a lot of us could potentially act on in clinic. Again, I have no disclosures. And I'll start out by just giving a brief background on sex and gender and why I think of these so much in Alzheimer's disease. So this slide has a figure that I think really depicts the difference between sex and gender pretty well. On the left, you'll see gender. And by gender, what I mean is the way that we present ourselves to the world as men or women or non-binary individuals. And then in turn, the way the world perceives us as those things and how the world treats us because of the way they perceive us. On the other hand, on the right side here is sex. And here, when I talk about sex differences, I mean biological based differences in things like hormones and chromosomes. I focus my research and my clinical practice on women and Alzheimer's disease because we know that 2/3 of people in the US who are diagnosed with Alzheimer's are women right now. That number is only growing. Right now, the total number in the US is 6.5 million people. And once women are diagnosed with Alzheimer's disease, there's evidence that we actually decline more rapidly than men do. So I'll point out on this slide, on the right-hand side here, these are people from a very large study that included a cohort from ADNI, an imaging US-based study, the Harvard Aging and Brain study, as well as an Australian study. And these folks who have amyloid in their brain when they enter the study, women on cognitive tests are performing better initially than the men in blue here, but the women's scores over time decrease faster than the men's. And by about 5 years, these women are now performing worse than the men, despite coming in performing better. At the same time, women are impacted by Alzheimer's disease, not just on the diagnostic side, but on the caregiving side. So just as women are 2/3 of the people diagnosed, they're also 2/3 of the caregivers for a loved one with dementia. This number is even larger than the number for people diagnosed. The total is 11 million right now. And it's also true that the women who are caregivers are more likely to quit their jobs to provide full-time care to a loved one. And about 1/4 of those people are also in what we call the sandwich generation. So these are folks who are caregiving for a loved one with dementia, a parent or a grandparent, and they're also caregiving for young children of their own. So having kind of a double caregiving burden. So now I'll shift over to talking about, in general, some sex and gender-based risks for Alzheimer's disease, and then also focusing in on two specific ones. So with Alzheimer's disease, the story used to be that women have more Alzheimer's because women live longer than men on average. And we know now that that is not the whole story. It's true women live longer, and it's true that aging is the #1 risk for Alzheimer's, but there's more to the story. In this graphic, I'm showing some of the areas of research that have really pushed things forward in terms of why women have higher rates and why women might decline faster. Some of these factors are biological, they're related to our sex, and I'll talk about two of those. One is ApoE4 status. So we now have research evidence from some studies that shows that when a woman has this most common risk gene for Alzheimer's, she actually has potentially even double the risk of getting Alzheimer's than a man with that same allele. Another factor that's related to our sex is menopause. So only women go through menopause, and of course men do have an andropause, but it's not implicated in the same fashion. And at menopause, women lose estrogen, which is a memory supporter, and this may be part of why we have greater rates. Some of the factors on this slide are more related to our gender than our sex, so the way the world treats us because we're women. One of those is education. So this picture has changed over the generations, but in terms of the folks who are currently being diagnosed with dementia, it is still true that women often had less opportunity when it came to education. And unfortunately, education gives both protection against Alzheimer's as well as cognitive reserve that can help with cognitive aging beyond that protection. Then finally, there are some things on this slide that really it's tough to parse out what kind of a factor it is. Is it a sex-based risk? Is it a gender-based risk? And one of those is stress. So stress and depression are implicated as risks for Alzheimer's. And in this box, we know that depression is more common in women. We know that stress, the types of stress that people experience, they are different if you ask a woman what types of stressors she's been exposed to over her life. And if you ask a man that same question, on average, those things are different. So these two factors are ones that they really truly are an interaction of things that the world brings to us and things that we bring to the world with our bodily systems. But from here on, what I'm going to do is give a little bit more detail on menopause and stress and how these two factors are emerging as potentially important risk factors for Alzheimer's disease in women, and what we can potentially do about that practically in clinic to facilitate resilience. So, menopause is some of the interest in studying menopause in Alzheimer's disease is because of this coincidence in timing. So the average age of menopause right now is about 53, and amyloid, that protein that builds up in a pathological way in Alzheimer's, begins to develop in the brain approximately 1 to 2 decades before Alzheimer's symptom onset, which is usually in the mid-70s. That puts that building or accumulation of amyloid happening right around the time of menopause. I'm showing here a really basic schematic that depicts how hormones change in pre, peri, and post-menopause. Most of the research when it comes to Alzheimer's disease and menopause has focused on estrogen effects, whether we're talking about human studies or animal studies. So, and I should say the reason why that's true is that we know that estrogen supports memory, and it is also anti-pathology when it comes to Alzheimer's. So estrogen in animal models has been shown to reduce amyloid and tau, or stop or at least stop the aggregation. So research focused on menopause and Alzheimer's disease found that, this isn't just a coincidence of potentially building amyloid at the same time we're losing estrogen. So there is a measurable dip on average in women's memory around the time of menopause. I'm showing here a graphic from a paper that looked at verbal memory across the menopause transition. And what these researchers found was that at baseline, before menopause, women had their baseline memory, and then as they went across the transition, that memory score dropped significantly, and it was worse. It's worst in the late transition. Then there was some recovery after menopause. Again, this is an average story. So there are some women who recovered pretty well, and there are some women who didn't recover in terms of their memory. Interestingly, this isn't just a story about memory that we can measure with a learning test, trying to remember words. We also can measure a dip or a change in brain function and brain structure across the menopause transition. I'm showing here an example just of brain structure across the transition. And this is from a recent, very large study that looked at a number of different markers of function and structure, and saw that there are measurable changes in gray matter, white matter, and activation. I'm showing here on the top 2 rows, this is gray matter change, and the bottom 2 are white matter change. What I'll point out is that just like that memory dip, in some regions like the precuneus, which is critically changed in Alzheimer's disease, there's a dip, just like a dip in memory. It's not true for every region. So there are areas of the brain where we're seeing more of a linear decline or a drop after menopause even. Similar to the memory profile, some women didn't recover the gray matter loss or the white matter loss, even in these regions where on average women were showing a dip or a recovery across the transition. And so there's a lot of interest at this point in whether or not there are certain women who are just more at risk and susceptible to the estrogen loss and leave menopause with more vulnerability than they came in with. I did want to say, though, although a lot of the research to date has really focused on estrogen, it's the primary driver. It is, the topic of hormone replacement therapy largely centers around estrogen, but it's obviously not the only hormone that's changing across the menopause transition. And recently, there have been some excellent papers published with animal models that suggest that the culprit, when it comes to memory, might actually be FSH that causes change in memory that persists. So another area that research will actively have to pursue in humans. Okay. So menopause is happening at midlife, and it's potentially increasing our risk as women. What about this other factor I said I'd talk about, which is stress? So before I even go down the road of stress, I want to be really clear about what I mean by stress, because different people can mean different things when they say it. I mean 2 things. One of those is stressors, so stressful events that we are exposed to. And again, these are things that differ between men and women on average. So on this diagram, which is great, it gives examples of external world stressful events. Internal medical conditions can be an event like that, and even recalling stress in the past can activate that stress response. The other thing I mean by stress is stress response. So here on this side of the diagram, you can see there's a physiological aspect of stress and responding to stress. And what we know is that, so women differ based on our gender on what stresses we're exposed to, and based on our sex biology, we also differ in ways that our brain and bodily systems respond acutely and chronically to stress. And so these are things that I think about at midlife as well. In terms of what it could be about the stress response that's really meaningful for memory and Alzheimer's disease, I'll mention 2 pieces. And the first one is what most people think about when they think about stress, which is HPA axis functioning and cortisol. So cortisol is one of those end products of that HPA axis activation. It's produced in response to acute stressors. And the response, whether it's immediate and acute or prolonged due to chronic stress, differs by men and women. When cortisol is dysregulated in a chronic fashion, it has been associated by various studies with poorer memory more acutely, as well as reduced plasticity, increased cell death in the hippocampus, that brain region that's important for memory formation, and also with increased long-term risk for both generally dementia all cause as well as for Alzheimer's disease specifically. The other aspect of the stress response that I'll mention is inflammation. So inflammation has received significant attention when it comes to risk for and development of Alzheimer's disease. And so we know at this point that inflammation in the brain actually facilitates Alzheimer's disease pathology buildup. So when there's neuroinflammation, you have more easily buildable amyloid and tau. And then unfortunately, when amyloid and tau are building up, they also produce inflammation in turn. So there's this vicious cycle in terms of cerebral inflammation. But what we also know is that the same inflammation that's throughout our body, and that's what we think of in terms of stress response a lot of the time, actually impacts the level of inflammation in the brain, particularly if we're talking about something chronic. And then finally, inflammation, we can think of it as related to part of our immune response, which we know does differ by sex in some ways. So coming back to this diagram, again, stress and menopause, and the reason why I'm talking about them within the same talk is that we now have at midlife for women, we have different gender-based stressor exposure. And the one that I'll point out, there's research that shows that women have more relationship-based stressors, more kind of threat to life-based stressors on average. But maybe the most important one to think about in the context of Alzheimer's is that caregiving, quitting the job, sandwich generation type stress that's impacting us at midlife more than men. And then we pair that with our sex-based differences in stress response, particularly with that chronic stress. And at the same time, we're losing that estrogen. And unfortunately, estrogen is one of the factors that can regulate both inflammation and cortisol responses. So just to kind of put those two risks together, there are many reasons why women might have higher rates of Alzheimer's than men and worse trajectories than men. And ultimately, for women to have these higher rates, the answer is very likely multifactorial, and it might differ woman to woman. But at the same time, there are some factors like menopause and stress that can be acted on or discussed in productive ways that can foster resilience in women at midlife. So I'll switch to resilience. As I enter this resilience part of the talk, I do want to acknowledge that in my clinic for Alzheimer prevention and in general, when we're talking about reducing risk for dementia, it's not just menopause and stress. So I'm showing here the list of factors that are thought to be classified as modifiable risks for Alzheimer's. So I understand you all have probably heard about these already. But again, just acknowledging these factors are all critical. I'm talking about 2 additional factors today that may also make an impact. So returning to menopause. When it comes to menopause and how to foster resilience around estrogen loss, the research behind what to do about it, and when I say that, I mean hormone replacement, it's controversial, and there are still no entirely clear answers in my view. So there are a couple of things that we have pretty good evidence for that can guide things in older women and in much younger women. So most of the data that came early on about what HRT could do for people at risk for dementia or what could do for the average aging woman, showed actually that in women who started HRT when they were long past menopause, they actually had quite terrible outcomes. So higher rates of cardiovascular disease, higher rates of cerebrovascular disease, higher rates of Alzheimer's disease. So starting HRT late is not recommended at all. And on the other hand, there is fairly good evidence for starting hormone replacement therapy having benefits in the long term for those women who go through, for example, a surgical menopause in their 30s, to kind of imitate that natural cycle of estrogen levels. But it's the middle that they call the window of opportunity, right around the time of menopause, that remains an area of active research where there is not a straight answer on yes or no, should you give HRT in someone concerned about dementia risk. There are studies coming out to support it. Some of these studies support use of HRT generally. There's a recent study that was done in 2021 on more than 400,000 women. It was a retrospective study, and it did show that in women around that window of opportunity, so that kind of appropriate time to take hormone replacement therapy, if they were on that for more than a year, they had reduced rates of dementia and Alzheimer's. Other active work right now suggests that if we're going to look at the effects of HRT in the long run, we might actually need to figure out who we should be giving the HRT to. And in some studies, it's coming out that it's people who are at risk for Alzheimer's specifically are the ones who might benefit most from starting that HRT. And then finally, the research question right now is, can we build a better HRT? So is there a way that we could maybe capitalize on those findings with FSH? Is there a way that we could think about different estrogens than we're currently using in HRT, ones that potentially target better the symptoms that we want to treat without also creating the side effects of dementia increased risk or other types of risks associated with HRT? So in terms of how you can promote resilience from a practical standpoint, I do just want to acknowledge, in terms of clinical practice, there is not a definitive answer for HRT around the menopause transition, and it has to be an individualized discussion and decision that you all are all equipped to do. But what can be very helpful is having a discussion and countering the stigma around just discussing menopause. So I wish it was another way, but a lot of women that I work with, they're hesitant to talk about menopause symptoms. They feel like it's something that they just have to go through, so why even bring it up? And for women at that age, oftentimes, if they don't have hot flashes, they also might think that they're doing just fine and not realize that sleep disruption or depression or feeling like their memory's not very sharp all could be part of their menopause transition. So just talking about that full picture and providing some support for those things that might come along with menopause for some women can be very helpful. Okay, so when I shift back to stress and resilience, I know that stress is not on this list, and I want to make a little bit more of a case for why I think stress should be on this list. So stress response, I talked about having two components that I'm thinking of, which are cortisol and inflammation responses. And on this list of modifiable risks for Alzheimer's, all of the factors in purple right now have either been linked or are currently being looked into because they have cortisol or inflammatory abnormalities as precursors or as outcomes. So when I think about stress, I think about it as something that can give us an insight into risk and also might be something that that can be malleable, that we can actually intervene on early and potentially impact the effect of other risks. Okay, so in terms of stress, it is true that exercise is a good buster of some of the stress responses that can be dysregulated. I'm showing here an example from a study that looked at cortisol response to a stressful situation in people who either were assigned to do low intensity exercise like walking, moderate, or vigorous. And what you can see, so these are the low intensity folks, the moderate, and then the vigorous. And the more intense the exercise intervention was, the more normalized that cortisol response was to the immediate stressor. And I believe this was the Trier social stress test, where people had to give a speech in front of a very critical audience. In addition to moderating the cortisol responding to stressors, exercise also does have impact on what has been termed an anti-inflammatory profile. So across different bodily systems and organs, there is a positive change for folks who exercise regularly or participate in exercise interventions when it comes to inflammation that's long-term. So exercise is a #1 stress reducer in clinic, and that people may not think of as something that can also improve body systems related to stress. And the other top recommendation that I talk about in clinic is meditation. So similar to exercise, regular meditation and acute meditation can lower blood cortisol and inflammation, and it can reduce that self-reported stress if you ask people about it. I'm showing a slide from a very recent paper for the reason that when I talk with patients about meditation, if I get resistance, it's usually because people say, well, I don't have time for that. I'm not a Zen person. I can't shut my mind off. And this is data from an app-based program called the Healthy Minds program, where the experiment was for 4 weeks to use this program, which walks through education and mindfulness meditation, that type of meditation where you're really supposed to pay attention to your breath, notice thoughts, and let them go. And what the study found was that over 4 weeks, and I should say the study was conducted in teachers during the early pandemic. So over 4 weeks, mindfulness improved, the active group is the orange. Loneliness decreased, ability to give yourself compassion increased, as did well-being and other variables. And when the researchers checked back in after 17 weeks, those things were maintained, or even, they're comparable for the most part. Well-being might not have held up as well as some of the other ones, but the message that I think that this sends is that when we look at variables that are related to acute or chronic stress, even a short intervention of 4 weeks is doing something very meaningful. But you might be thinking, well, what was the intervention? How much time did these people have to spend? And the answer is less than 5 minutes a day. So I think that the message that I try to give my patients is, we're not talking about something where you revamp your entire life with meditation. We're talking about practicing a skill briefly, but doing it regularly so that you can give yourself a means of improving some of these cognitive strategies and decreasing stress and sometimes depression or anxiety as well. So in terms of promoting resilience from the stress side of things, I think just asking about stress can be so powerful. Something that I see a lot is that people will say, well, everybody is stressed, they'll laugh. We're still in the pandemic. And folks will say that even if they have an incredible amount of stressors, caring for multiple family members, having multiple deaths in the family. And folks might not recognize that their stress is at a level that could really be causing them some physical harm or mental health harm. But being asked that question sometimes can really open it up. And then, exercise and meditation, just seeing those as ways that people can get through a challenge like we're currently all going through in an easier fashion if they can make those things priorities. So just kind of putting this all together, my work clinically and in research really has emphasized for me that gender and sex are both individually and interactively important when we think about Alzheimer's disease risk, as well as folks who are diagnosed. And really just taking the time to educate people and provide some simple interventions can improve well-being in the moment, just knowing what you're facing and knowing what your symptoms mean, but then can also really help women at a time when they're vulnerable, when we talk about midlife, to really help themselves to have resilience as they go forward with aging. So I did want to just thank all the people that help make what I do possible, my clinical team, my partners and collaborators. And thank you so much for coming to this talk.
Caldwell, thank you so much for this wonderful talk. It's such an important, critical area, and I really appreciate how you have synthesized not just the literature, but also some practical and pragmatic things that our community here can take with them as they enter their afternoon clinics. And I'm sure there are lots of questions. I'm happy to open it up if you have some time to stick around and answer a few. I see one in the chat already from Deborah Tillman. Deborah, can you unmute and ask that, or do you want me to?
I was just wondering if that replacement was estrogen alone. Was it just by happenstance that they were doing it for other reasons? Or was this a combo and high dose, low dose? Just kind of wanting to know more about that.
Sure. So the study that I mentioned with more than 400,000 women, it was retrospective, and it looked at prescribed, it was an insurance-based poll. So they looked at women who were prescribed any HRT for menopause. So the cause was menopause, but it could have been anything. And I didn't say this, but what they found was that they actually saw everything reduced dementia rate, no matter what type of hormone replacement therapy. And they had synthetic, natural, estrogen only, and combined. And it was the natural estrogens that seemed to have the largest effect. But even with a massive study like that, I think that's something that I would still say, let's see some replication and further work on it. And of course, it's retrospective, so there are some disadvantages to that design being the only look at that kind of data, but it just has the advantage of having such a large sample.
Other questions? I see Allison has one.
Yeah, thanks. Jessica, I'm just wondering if you feel like this data translates across other dementias as well.
It is a good question. So I think that the menopause piece, I couldn't say. So it does seem like there is applicability from that large study across, but when we're thinking about things like, can we be more precise? And is it genetic risk that really could bring some of the benefits? I think that's an open question in other types of dementia. But the stress-related recommendations and threats, I think especially vascular dementia, I think that we could do a lot where, even if stress isn't on the list of modifiable risks for Alzheimer's yet, we know the effects of chronic stress on the heart. And we could approach it from a double risk reducer in terms of cardiovascular risks and cerebrovascular.
And Pranjit.
Really enjoyed your talk, fascinating. And I am curious, what do you make of the fact that women were scoring higher and then just plummeted compared to the men with regard to their cognitive function? Was that set in motion before as well? Or is there, just curious, what do you think? What's your insight?
Absolutely. This is something that I think a lot about. And I think there's two things that do it. The first one is that, so I think it's a biological memory-based reserve. So on average, women have better memory than men do. And, that's not to say there's a lot of differences where women are scoring higher. It's really specific to verbal memory. But of course, when we're talking about Alzheimer's disease and verbal memory changing first, I think that, in my research and others, we've shown that women's verbal memory can hold up to greater levels of pathology, including amyloid, tau, and neurodegeneration before you see the memory symptoms. So I think that's a piece of it. But the other piece is just, I think, potentially error on our part in diagnosis. Because, like, as a neuropsychologist, when a woman comes in to get diagnosed with Alzheimer's, the primary test is verbal memory, because that's the first thing that's impacted in Alzheimer's. So if women have it better and they're not showing the symptoms yet, I think we're diagnosing, when we say this woman has Alzheimer's, she has more pathology in the brain already than the men do. So it makes sense that her trajectory is going to look different, because she's already farther along when it comes to what's actually in the brain.
That is so interesting. If you have more interesting insights like that, please share.
Yeah, I mean, I think, for those of you, I don't know if any of you work with neuropsychology, but I think there's definitely a critical mass gaining where a lot of us are thinking about using different sorts of tests and different sorts of cutoffs for women. And so I think this is coming. And I mean, so this is something I've been researching for 6 years, and just this year, our clinical practice switched our memory measure. So it's slow going, but it's coming. Yeah, anything else that I can speak to, please let me know.
Well, I know that the research and the studies you presented were showing the stress was a major factor, and yet intuitively, I just wonder, it just seems like men don't deal with stress as well, and it seems like women are, and this is completely biased, intuitive, just, it seems like women are more likely to go to yoga classes, more likely to seek, meditation. So I'm just still wondering, like, why are women more stressed? Is there a good article or a book that you'd suggest?
Yeah, so a good question. I think if you want to read any articles, so George Slavich is the man who designed the stress assessment that I use in my clinic and my research. It's called The Strain, and it looks at kind of lifetime exposure to stress. So I agree with you, but I think what we're talking about in both sides of your question is essentially gender bias. So I would say it is more acceptable for women to go to yoga and meditation. Like it's more, I think it would be less expected for men on average. Certain circles absolutely would have different cultural expectations. But at the same time, the thing that, and this is just anecdotal, but the thing that I hear from women coming in wanting to do prevention is, well, it's all on me. I'm the family go-to. I provide all the transportation for my kids, for my parents who need to go to their medical appointments, and I just need to do that. And I never hear that from the men, because there is this cultural expectation that women take that on. So while I think women may deal with stress better when they can, I think that in this cohort who are burdened more by caregiving, that the expectation on them is, it doesn't matter, you got to get it done. And so the threshold for them to act on it is so much higher, because they just think it's their responsibility to take it all on and put themselves down on their list.
Thank you so much for answering, because even asking the question felt like I had so much bias in just the question. That makes a lot of sense. And have you looked at gender differences across different cultures then?
I haven't. I do think that that's a really important question. So one thing that I'm hoping to do in my research is really kind of make sure that I'm being inclusive on who's able to come to the clinic, who's in the clinic. And some of that I'll be restricted geographically. For example, I have a really good population of Filipino women where we are in Vegas. So that will be a group that will be much easier to study in the clinic than some other ethnic groups which aren't as populous in Las Vegas.
Jessica, I just wanted to say thank you so much for that presentation. It gave me so much to think about and thinking about my experiences with husbands and their wives have Alzheimer's and they don't. And when you were saying about the assessment, he noticed his wife because she couldn't sign her name on a car lease document. And so that was his first and only clue that something was wrong. And so when I think about our own bias, you know, how women present well and how they have this ability to kind of turn things on and off when they have to perform in front of a doctor, things like that. So knowing that we're kind of addressing that aspect of our human nature and our intuitive ability to kind of shift according to whatever is being put in front of us, and knowing that we're maybe getting better at testing and identifying, so that way, like you said, you know, we can identify earlier and maybe intervene earlier or do more teaching about that, especially in this situation. So I was kind of floored. I was like, a signature. And then when you said that, I was like, oh, that makes complete sense, right? And so I really appreciate all that information you had to share. Yeah, that was great. Thank you so much.
You're welcome. And I just wanted to add too, I don't want to make it seem like the gender bias is only bad for women, because that man who brought in his wife, he doesn't have the societal expectation that he should be a caregiver. And so many, many men that I see in that position, they go through a whole lot of psychological, like cognitive dissonance, distress, because they don't feel like they have the skills. They don't feel like it's manly to be in that caregiving role, even if that's not something that's kind of at a conscious level. So yeah, we've got some work to do on both sides for sure.
And Jeff Kaplan.
Yes, thank you for the talk. It raises a whole bunch of questions, everything from association to causation, which are really seems very hard to separate. And this seems to have parallels with ACEs for children. With the more ACEs they have, the more medical diseases they have as adults. And so what I'm grappling with is, obviously it's hard to put a number needed to treat. It's hard to put anything other than an association relationship to this. And yet it comes down to what becomes most important is, how do we help people change behavior? It is how I'm sensing it, because almost all of these are behaviorally based. And at least in primary care, this is what we grapple with virtually everybody we see and with which we have limited success. And so I suppose what I would return to you then is, have you found a strategy, because if we could change behaviors, we'd have a lot less pathology. Have you found a strategy where you're able to use this? And I assume the people who see you are highly motivated, and that's not everybody that I see, which has helped people to alter their behavior.
Yeah, I mean, I think I have that advantage. So I've got motivated patients, because a lot of them have to wait a long time to get in. They're traveling to see us, so they are highly motivated. And yeah, I think that's a part of it. And I'm also able to spend a lot of time with them. So because of the structure of our clinic, I can be with one woman for 45 minutes to an hour, which isn't common anymore in many medical settings. And I specifically ask some tough questions with them, because I have a 2-part appointment. So I don't need to cover all the medical side. I can spend more time on stress, and I can spend more time on life kind of composition. And then our patients will see someone else. So there's some follow-up. But I think what I've taken away is that, despite everything I just said, there's something about family risk, that if you know this person's parent had a devastating disease like Alzheimer's, those are the folks who you can hook in with the motivational piece, because they, number one, they feel scared, and number two, they feel alone, and they don't, if you can just counter those two things, like, this is not your destiny, and everybody else that I see feels the same way, you can get some buy-in on behavior change. I don't think it's the things that I'm doing are magical, and because I have those highly motivated folks, but I do think it's, if you can tie it directly to something that they're worried about coming down for them in the future, that you can move it. And if you can tell them you can change it, because that's hard. A lot of people just think about dementia as something that, well, it's eventually I'll get it.
Brock?
Thank you so much. That was an incredible talk and really, really super eye-opening. And I guess part of what I'm sort of thinking about is like the slide that you showed where there was like the time frame of like the pre-menopause, perimenopause, and postmenopause, and just in the same way that it's so hard to tell when does dementia start, you know, so hard to tell when does menopause start, and then also like when does menopause end, right? I mean, there's also like, I think we were all learning how there's just this very, very, very long tail to menopause, and that it's not, or I guess like that, or in terms of, or when do menopausal symptoms sort of end, and so I guess thinking back to that slide where it was post-menopause, it really sort of raises for me the question of like, how long after that sort of beginning of menopause was that time point, and what happens if you follow it out over sort of years in terms of, do people continue to recover, or is that sort of graph that you showed actually, no, this is like their new baseline for the next sort of 2 decades?
It's a great question. So to the second paper I showed with the brain effects, they did look at cognition as well. And then they followed women, I believe 2 years after, and they saw recovery for most women. They did identify a group of women who did not recover memory or structural volume. And so definitely kind of thinking about this as a way to identify those people who are vulnerable to it. But yes, so it's for most women, it's a transition, it's not a decline. And then to your other point, I mean, I don't think women know most women, when they have menopause symptoms. And part of that, I think, is what we've been talking about. It's like, we talk about menopause, you just have to deal with it. And so there's not a great awareness of some of the more subtle symptoms or non-hot flash related symptoms that, a woman will come in and say, oh, I'm definitely premenopausal. And then you ask the questions about sleep or memory and, regularity of cycles even, and it's clearly not your peri at least, or postmenopausal on the other side. Am I done? I don't know. But I would say from a research standpoint, there's work being done to improve the cross-study reliability and definitions. And in particular, there's something called the straw criteria, which are used in research, which are based on, there's a core set of definitions for how you define the pre, peri, and post, but then they also have supplementary kinds of definers. So I'm talking about blood values. So it's a way for, if you have or don't have certain materials at your disposal in your study, you can hopefully still accurately define what stage a woman is. And they break it down a little bit more consistent with that first paper I showed, where you've got pre, early pre, or early peri, late peri, and so on. So absolutely agree with you. And I just hope that the research community keeps working to get that more standardized.
And it just like strikes me of how there's that same kind of super fuzziness of like what's normal aging versus what's, pathological cognitive decline. And so what is normal aging versus what are postmenopausal symptoms? I mean, it's like, it's just hard. It's just super hard.
Yeah, and I mean, I think I try to, especially around that postmenopausal time, as long as I'm not seeing anything real concerning on the cognitive testing, reassure, but then reassess. And definitely with the cognitive cutoffs, if I'm seeing women who are older, like, in their 70s, and it looks a little too low in the memory domain, I will be much more conservative and say, come back in a year. I want to see you in a year, because I don't want to miss that woman fall off the cliff if she is kind of right on the edge of normal aging and a process like Alzheimer's.
Yeah, and it's also it bumps up against the other big risk factor that people get so concerned about, which is sleep. And they get so concerned. It's like, oh, I'm not getting 8 hours of sleep. That's putting me at higher risk for Alzheimer's. I need Ambien in order to get my 8 hours of sleep to prevent me from getting Alzheimer's. And I'm like, no, 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 no. Like, that's not what you need. And so I mean, I think, right. Yeah. I mean, so, right. I mean, so it's just that sort of like catch-22 of raising people's concern to a level where they can actually do themselves harm because they're so freaked out.
Yeah, and I think too, especially here, I'm really lucky I have a health psychologist in the building who does cognitive behavioral therapy for insomnia. So, it's not, you can't do that everywhere, but I think, even without that, just educating people on your heart is in the right place. You want to have better sleep, but let's try something else to see if we can get the same outcome without another risk. Because yeah, I think that's another one that people struggle with because they're scared.
Fun conversations, good questions. I'm wondering if this ties into any clinical issues that anyone's dealing with currently.
I'll volunteer one, Jessica. I'm a neuropsychologist at UW Medicine, and one of my I recently, like, all this is strongly resonating with me because there's about 2 weeks ago I had a patient who came in that perfect storm of, she's right, female, 50-ish, and kind of talking and about memory concerns. Obviously is what brought her to me, but then in the context of where she was at in terms of menopause. And we had a lot of these conversations. And what was interesting was her, and I was doing the best I can. You were much more eloquent today than I was definitely in trying to explain this kind of relationship of menopause and what that can look like in terms of cognition, and whether to be worried versus not from a neurodegenerative perspective, and trying to not give kind of false hope or negative, completely wrong expectations that everything is going to be fine, because I just don't know. And I wish that, and I hope for you that, things will resolve and things will get a little bit better. I'm wondering if you have, just given that like I said, I was definitely not as eloquent as you were. I'm wondering if you have any tips or ideas, kind of ways to convey this information well that does not give either false hope and kind of falling in that appropriate zone of information providing without leaning somebody in a particular direction that could lead to disaster.
Yeah, and I think this is the thing that lots of us struggle with, but I would say, I go for validation and reassurance for the vast majority of people, because the evidence out there is that you're not making this up. It's not in your head. For the majority of women in studies, we can measure a memory dip, but it is a dip. Most women will recover back to their baseline after the transition is done. And then kind of just saying, but trust yourself. If you find yourself, 2 or 3 years down the road, feeling like, it never got better or things are worse, then come back. And we'll test it again and compare you to you. So I think for me with the menopause piece, I don't give women kind of a bleak picture, because it really is, I think it's a minority of women that have really poor outcomes. And so I think kind of helping women, I guess from that psychosocial side too, if I can send someone out not worried about it, can I get them engaged in some of these other behavior practices and just say, these are the things you can do to hopefully not be back here. I think that's totally appropriate. I think it's different if you have someone, for example, who had early menopause, oophorectomy, no hormone replacement, and their testing looks a little bit concerning. I would just be honest about, the oophorectomy part. Like, some people after that do have some difficulty, so let's keep an eye on it. But it is really tough.
Anybody else? Going once, going twice? Oh, Dr. Gastick.
Could you say a little bit about what your guess is in terms of the timeline where we might have randomized controlled trial data on hormone treatment?
So those longitudinal RCTs are ongoing right now. So there are some folks who are, I hope within the next, it's certainly, I tell my patients that I think within 5 years, we're going to have better guidelines, at least on some things. So whether it's, better targeted estrogens, that's one of the trials right now that I'm excited. I hope something comes of that. Or whether it's more of a look into who should be on the therapy, because I think that's got to be critical. But it really took a lot of years, and in my view, honestly, it took some women running the big studies to follow people longitudinally, because that area of research was just under, it had less attention, less activity.
I mean, I'll just like share, like, as a primary care doctor who was going through residency in the mid 90s, at a time when hormone replacement therapy was the sort of exciting thing that everybody should get, and then just the Mack truck of the Women's Health Initiative. I was like, oh no, actually everything that we've been saying for the last decade is wrong, and we shouldn't be prescribing hormone replacement therapy at all. But I've always really looked at what the immense quality of life benefit of using hormone replacement therapy to treat symptoms during the sort of initial intense menopausal symptom phase, far outweighing the small risks that came out of the Women's Health Initiative. And so, to me, I have always been a, relatively pro, hormone replacement sort of prescriber for menopausal symptoms. And so I think that it would be immense if we really had that randomized controlled trial data that showed that it actually improved cognition, even especially long term, because I think that there is a tremendous need to overcome the resistance to prescribing hormone replacement therapy that came from the Women's Health Initiative. That, I mean, I see it. I had a patient last week who, their gynecologist refused to prescribe hormone replacement therapy because it had been too many years since their menopausal symptoms began. And they're like, oh no, this is too dangerous. I can't prescribe this to you because of your cancer risk. But clearly she was having symptoms that were being improved by the hormone replacement therapy. And so I really would be super excited if this randomized controlled trial data really helped to overcome some of that resistance that I think really is out there.
And I mean, I think it's really so needed, because it's confusing. Patients will come in and say, why am I hearing all these different things? I'm so confused. And I will say, well, if a scientist did a literature review, they would probably come away with a confused initial response as well. So we need that RCT data.
Anyone else? Dr. Percy.
I'm gonna throw a left field question, just because my mind is percolating on a Friday afternoon. Thinking, and I'm sure the answer is we just don't know yet, because we don't have the data. But has there been any movement or thoughts thinking around our transgender patients and with HRT, and how that may or may not be impacting cognition, or if you've just kind of heard anything, if there's anyone working on that?
So I think the good news is people are working on that. The bad news is it has to start so far back at the literal level of, you know, how do we define sex and gender? And what are the cells that we offer to people to define themselves as? It's literally this, within the past year, we're publishing papers on sexual orientation and gender identity and what we all mean when we say it. So that is literally how far back that work is. But just from my perspective, I think, you know, there's a lot of people doing really great work on dementia risk and dementia in people who are non-cisgender, non-heterosexual. So really just, you know, expanding the base of people. But from an estrogen perspective, I would say that, you know, there's a lot to think about. And, you know, it's everything from puberty to menopause, and what type of puberty did you have? Did you experience menopause? And I think it really brings things out of that male-female binary to more of a situation where we have to think, what is your hormone complement lifetime? And I don't know how we put boxes around that either, but I think we have to step back and say, okay, if hormones are what's the critical piece here, then how can we more accurately do that beyond kind of forcing someone into a box, or saying, as some studies very recently unfortunately have, is, you know, sex assigned at birth, that's what's important, that's the only thing we look at, which is unfortunate and silly, I think.
Thank you. Yes.
I had a question just out of curiosity, based on what I was mentioning earlier. And I didn't know if you had any experience with talking to husbands whose wives do have Alzheimer's, and maybe kind of encouraging them to take a different look at their role. So I work in palliative care, and so I do home visits. And so my goal is, you know, to talk to the family as a whole, especially in these situations. And sometimes it's really easy because there's daughters or daughters-in-laws or other parts of the family that can kind of, sisters that can step in and assist. But I didn't really know in your experience how you have that conversation with kind of their male counterparts on, you know, looking at this role and looking at how they can support their wives, you know, even from simple things like bathing and dressing, or, you know, just helping with day-to-day activities, about having that conversation with them.
So my approach in my current setting is that I partner closely with social work. So if I'm the one talking with the family in a feedback session about, you know, this is definitely dementia, I see it as my job to make sure, if I can at all, that care partner knows what's coming in general. You know, this is going to continue getting worse. You will need help. We have someone here who can walk you through that kind of help. And so some people, I think, are just at a denial stage. Some people are at I need some resources stage. And some people have well, I'm okay with the bathing, but I don't know how to talk to my partner anymore, because they forget everything that I say, and it drives me up a wall. So we kind of partner with our social work department to help, whether it's a man or a woman, hopefully kind of work on the piece of the caregiving process that they need. But I don't do any therapy here, and so I don't see the partner multiple times unless the person comes back for another neuropsych.
Well, I'm not hearing any other questions. We do have a couple of minutes, so we can give you a couple of minutes of your day back. Again, Dr. Caldwell, I want to thank you so much for sharing your time, your expertise, and just the work you're doing overall. This has been a wonderful session. Deeply appreciate you taking the time. Allison, yeah, absolutely. Allison had an announcement also that she wanted to make.
Yeah, just really quickly that I am tabulating the CME from June of 2021 through the end of May 2022. So I'll be sending out email in the next week or so, giving people next steps in case that's something they'd like to take advantage of. Thank you.
Outstanding. And speaking of CME and upcoming things, our next session will be Friday, June 24th. And our own Carrie Rubenstein, Dr. Rubenstein, will be talking about evaluation and management of pain in dementia. So stay tuned for that. You will, of course, receive a survey for today's session, and we'll happily share the results with you, Dr. Caldwell. Unless there's anything else, I will say thank you so much for continuing to attend and participate in this great session. It's, we crested the 2-year mark just recently here, I think. So onward.